Here we reach to the very terminal part of this academic year, and after quite a few times of postponement, now this fortunate evening has come, and when we are now about to start our long planned discussion on pediatric GVHD. As we know that in the recent era, with better selection of the donors and different manipulations, while hematopoietic stem cell transplantation has really opened several avenues of treatment for benign as well as malignant hematological conditions in children. Graft versus host disease remains one of the threatening complications which can have significant impact on the transplant-related mortality and morbidity and subsequent quality of life, and is obviously a dreaded complication feared both by the transplant physician as well as by the patients. So to discuss on this, we have our eminent panelists today. First, we'll start with a case discussion as usual. So there will be two fellows from the Narayana Hospital, Bangalore, who will be presenting two interesting cases of DVHD to start the ball rolling. May I first request Dr. Siddharth Totadri to start his case presentation, which will be followed by a case presentation by Dr. Tanusri. Over to you, Siddharth, sir.
Good evening. Are my slides visible? Am I audible?
Yes, Siddharth,
you are clearly audible and is visible.
Yeah. Thank you, organizers of this echo session. And thank you, Sunil sir, for this opportunity. I'll be presenting a case of chronic GVHD. Dr. Tanush will be presenting a case of acute GVHD. So we had a 10-year-old girl with beta thalassemia major who was on regular transfusion and chelation. So she was a full match with her mother. Both the donor and recipient were the same blood group and CMV serology positive. So we conditioned her with a myeloablative conditioning with cyclophosphamide, ATG, fludarabine, and busulfan. And we gave her GVHD prophylaxis with cyclosporin and MMF. The source of stem cells was peripheral blood cells. And we chose PBSC because the mother was also a full match with the other sibling who had thalassemia, and we wanted to collect cells for both of them at the same go. We gave 6 million cells per kg as a dose, and she engrafted by day 12 for neutrophils, and a platelet had never dropped below 20,000. She had complications in the form of febrile neutropenia and mild veno-occlusive disease managed with supportive care alone. And by day plus 35, she had presented with fever and rash, and we had suspected her to be a MIS-C related to COVID-19. The serology was also consistent with a COVID-19 related MIS-C, and echo showed coronary artery dilation. At that point of time, we had to start her on a good dose of steroids. And when she was started on the steroids, we had withheld the MMF. And you can also see the chimerism table. The first chimerism sent on day plus 17, it was 95%. So we had withheld cyclosporin to facilitate improvement in the chimerism, which happened by day plus 26. And subsequently, the chimerism remained good. Now, coming to the GVHD part, around day plus 85, during the OPD visit, we noticed that she had a hypopigmentation in the oral cavity with a purplish hue. Suspecting onset of chronic GVHD, we had started with local measures with only Kenocort paste and clotrimazole mouth pain. But within 3 days, she also developed skin rash in the form of hyperpigmented papules on the scalp and back. And at this point of time, we had also started her on prednisolone at 1 mg per kg per day. We restarted MMF, which had been stopped during the steroid course for the MIS-C episode. At this point of time, because the creatinine was high, we did not restart cyclosporin. And after 2 weeks, this rash continued to progress to the trunk proximal limbs also. And at that point of time, we added weekly methotrexate, and we restarted a calcineurin inhibitor in the form of tacrolimus. Now, subsequently, she had a significant flare of the GVHD with bullous lesions developing on the palms and the soles. And she also developed matting of the eyelids with eye discharge and conjunctival erythema. So at this point of time, along with local measures such as clobetasone ointment, liquid paraffin, and also for the eyes, tacrolimus ointment, flutibact ointment, and refresh tears, we hiked up the prednisolone dose. And as a second-line agent, we added rituximab weekly for 4 weeks. And gradually, the skin lesions became thick. And for these thickened skin lesions, imatinib was added. She also had large oral painful lesions for which we added beclomethasone, swishes, and gargles. Now, just coming to the consensus criteria for classifying chronic GVHD, several organs can be involved. The main organs which are used for grading and scoring include the skin, in which this patient had, as you can see, maculopapular rash involving almost 50% of body surface area. And she had mouth involvement, as you can see, with some moderate symptoms, limiting intake partially. And she also had eyes with conjunctival involvement, but not with any loss of vision. She did not have any GI or liver involvement or lung involvement at this point of time, no musculoskeletal or genital tract involvement. So she fitted into moderate chronic GVHD as per the scoring system. And we use systemic drugs in the form of steroids, MMF, tacrolimus, rituximab, and imatinib, and local measures also. So these are the clinical pictures of the patient. You can see the oral cavity with the lichen planus-like lesions and also the hyperpigmented macules on the back. So subsequently, with all this treatment, gradually the lesions stabilized. There was improvement in the oral and eye lesions. We continued the local measures. Gradually, prednisolone was tapered. We continued MMF, tacrolimus, methotrexate. Imatinib also we tapered and stopped. By 6 months post-transplant, she had an episode of acute pancreatitis, which was managed with symptomatic current withholding septrin. By 8 months post-transplant, she remained stable, and we started tapering MMF while continuing tacrolimus and weekly methotrexate. By 10 months, she had a new onset symptom in the form of reduction in the vision of the left eye. Neurological causes were ruled out with an MRI brain, and ophthalmic evaluation revealed ocular GVHD. We added local measures in the form of cyclosporin, antibiotic drops, and with that itself, the vision gradually improved. So we gradually started further tapering MMF by 13 months post-transplant. Now she's 18 months post-transplant. 1 month back, she came with some new painful oral lesions and some vitiliginous skin lesions. So we have reinitiated a lower dose of prednisolone at 0.5 mg per kg per day. We are still continuing tacrolimus, weekly methotrexate, and MMF at a lower dose. And throughout this, we gave her antimicrobial prophylaxis. During the steroid treatment, we had actually increased the antiviral prophylaxis to Valgan and antifungal prophylaxis to mold prophylaxis with itraconazole. We supplemented IVIG when we found her levels to be low. And we also gave her flu vaccine. And after a year of stopping the initial steroid treatment, she also got her hexaxamine Prevnar dose. Currently, the child is doing well, and we are planning to gradually taper the prednisone that we have restarted. So just to quickly highlight some points, chronic GVHD in this patient, we can see the risk factors was PBSC as a donor source and a slightly older donor age. And like in our index patient, it manifests as around 3 months post-transplant. Although 100 days is a typical thing described, it is more related to the manifestations. We might have an overlap period. In our child, it manifested slightly earlier at around 85 days. And the treatment for mild GVHDs with topical drugs and low-dose steroid, in our patient was moderate. So we added systemic steroid at 1 mg per kg per day. With the flare-up, we added rituximab. And because she had some evidence of sclerotic skin lesions, we also added imatinib for her. And it's important to give supportive care to the patient to prevent infections and avoid live vaccines and supplement IVIG as we have done in the index case. Thank you.
Thank you, Dr. Siddharth. Dr. Tanushree, may you please start presenting your slides? Okay. Just try once. If not feasible, then I will project.
Share screen. Sir, you do it from your side only. I'm not
all right,
able.
No problem.
So shall I start? Shall I start?
Yes, please, Tanu, you can start.
Yes, sir. Good evening, everyone. I'm Dr. Tanushree, fellow BMT. So I will discuss a case of acute GVHD. Next slide. 12 years old female hailing from Hyderabad, known case of thalassemia major class 2, underwent matched unrelated donor HSCT on 20th January with PBSC as graft source. Conditioning was based on thiotepa, triosulfan, fludarabine, ATG. GVHD prophylaxis she received is cyclosporin, methotrexate, and MMF. Neutrophil engraftment was on day plus 12 and platelet engraftment on day plus 13. Immediate post-transplant complications were febrile neutropenia, grade 2 mucositis, steroid-dependent grade 1 GVHD. On day plus 17, she had maculopapular rash in the back and the trunk. So initially, she was started on topical steroid, and then prednisolone was started at 1 mg per kg along with cyclosporin and MMF. While she was on tapering dose of prednisolone, there was worsening of skin rash after 2 weeks of starting prednisolone. So prednisolone dose was increased to 1 mg per kg per day and was started tapering over next 2 weeks. While she was on tapering dose of prednisolone and cyclosporin, she had stress. So steroid and cyclosporin was withheld for a week, and she was continued on MMF. But at that time her skin rashes worsened, so we have started her on a steroid sparing immunosuppressant. Ruxolitinib was started, and prednisolone was started at a lower dose at 0.5 mg per kg per day, and then we increased to 1 mg per kg per day, and we tapered gradually over next 2 months along with tacrolimus and MMF, and in that over next 1 month her skin rash has improved. So post 10 months of HSCT, she has again presented with complaints of watery loosey stool 4 to 5 times a day for last 3 days, which were greenish in color, associated with mild pain abdomen and with no history of fever. So initially we have investigated her for infective workup. Stool culture was sent, stool for Clostridium difficile was sent, that was also negative. So stool biofare was sent, that is negative. After ruling out all infective workup, with a high degree of suspicion of gut GVHD, since she has a history of skin GVHD previously, she underwent endoscopy, upper GI, and sigmoidoscopy. And in that, there was grossly multiple aphthous ulcer in the duodenum and colon. And on microscopic ulcer examination, there was diffuse ulceration with crypt epithelial apoptosis with apoptotic abscess, which was suggestive of grade 4 GVHD. Later on, we also had done new imaging for her because of the persistent GVHD. So initial immediate management of her was with fluid resuscitation and electrolyte corrections was done. She was kept nil per orally, and we have started parenteral nutrition for her. Adequate analgesics were given. Initially, we started her on antibiotics, but once the infective workup was negative, we stopped antibiotic. And once we are diagnosed as GVHD, immunosuppressant was started. So she was at that time on tacrolimus as GVHD prophylaxis. So we continued tacrolimus and we started methylprednisolone at the rate of 2 mg per kg per day and budesonide. It was continued for 5 days. But after 5 days of treatment, she has worsening of symptoms with increase in stool frequency as well as the volume of stool was also increased more than 1,000 to 1,500 ml per day. So suspecting steroid refractory GVHD, we started her on rixolotinib along with methylprednisolone and budesonide. But after starting that also, minimal response was there with decrease in stool frequency for few days. Again, she had worsening of symptoms with melena and severe pain abdomen. So after she had worsening of symptoms with melena, we underwent repeat upper GI endoscopy and sigmoidoscopy. which was again suggestive of grade 4 GVHD, along with that viral inclusions were present. On blood, CMV copies were also 6,209 copies. So we started her on ganciclovir along with the immunosuppressant methylprednisolone, budesonide, tacrolimus, and ruxolitinib, which we continued for 2 weeks. But despite all these measures, her symptoms persisted. She continued to have melena. So we started her on third line immunosuppressants, which have little evidences, but we have started etanercept, TCR receptor alpha blocker, extracorporeal photopherosis, non-pharmacological management, and we have given cellular therapy with mesenchymal stem cells, which we continued for next over 1 month. Gradually, her symptoms improved and stool frequency decreased. And we have done nutritional rehabilitation also. And patient was discharged on ruxolitinib, tacrolimus, and budesonide. So this is the schedule of the third line immunosuppressant which she got. Etanercept, we have given her 8 doses twice weekly for 2 weeks, once weekly for 4 more weeks. Extracorporeal photopheresis twice weekly for 4 weeks and once weekly for 4 more weeks, total 12 sessions. And mesenchymal stem cells, 4 doses. So this is in nutshell her timeline of management of grade 4 GVHD. Post-transplant, immediate transplant, she had steroid-dependent grade 2 GVHD, which lasted for around 2 to 3 months. After that, she was asymptomatic for 6 to 7 months. Again, in 10 months, she had watery diarrhea, which was steroid refractory. We started her on second line ruxolitinib, in which there was no response. And after that, we have started her on third line immunosuppressant, etanercept, ECP, mesenchymal stems, one by one. And gradually, she improved over a duration of around 90 days hospital stay. We have discharged her on ruxolitinib, tacrolimus, and budes. At present, 24 months post HSCT, she is asymptomatic and she is now on tapering dose of ruxolitinib. While managing her grade 4 GVHD during her hospital stay, there are various other complications also she had, like CMV reactivation was there. It was ganciclovir resistant. So we have treated her with ganciclovir as well as cidofovir. She had sepsis and neutropenia. We have cidofovir and hyperbaric oxygen therapy, and she had also portal 1 thrombosis, which were managed conservatively during that admission time. So this is the magic clinical staging of acute GVHD, where the next speaker will describe more about it. There are 4 main organ sites which are involved, like skin, liver, upper GI, and lower GI. And grading is also there. Grade 0 is no stage or asymptomatic, and grade 4 is the most severe GVHD involving skin, liver, and upper GI. Thank you.
I'm sorry. So I had to just kind of terminate this because it's already 7:20 now. If your case presentation is done, can we move towards the first talk? Dr. Tanushree, your case presentation was complete. Am I right?
Yes, sir. Yes, sir. It was completed. Thank you, sir.
Yeah. So I will stop sharing here, and at this juncture, may I now request Dr. Sunil Bhatt to take over the screen. Sir is a senior consultant and clinical lead of pediatric hematology, oncology, and bone marrow transplantation at Majumdar Shaw Medical Center and Narayana Health City, Bangalore. He will discuss on the preventive strategies of GVHD in pediatric HSC. Over to you, sir.
Thank you, Preetham and Vandana, for first of all organizing this session and having us here. It's as you mentioned, it's a very important aspect to discuss in transplant, and we, a couple of cases which were just presented highlights, the importance of this important disease condition, and also the amount of work and multi-modal treatment which goes in the management of these cases. So I'll not spend more time. I think we'll have Chintan to speak mainly on the management of GVHD. So I'm just going to briefly talk on the prophylaxis of graft versus host disease, and then Chintan will take over from the management point of view. So, as we all know, the first transplant which was done was on a child, with acute lymphocytic leukemia. It was done from identical twin, and that was way back in 1957, 56 by Sir Donald Thomas, and we all know that he got Nobel Prize for that in 1990. But what happened after the first transplant, which fortunately was from the identical twin, but the second, third, fourth transplants which were done, again from the North America in Seattle, they had a very funny disease which was called a second disease at that point of time. And the second disease had manifestations of severe diarrhea, skin rash, and liver dysfunction. And in fact, the program was to be halted for some time because of this mysterious disease which was coming up after transplantation, which didn't happen in the first case. Fortunately, the first case was an identical twin, and that's why I think there was no manifestation of the second disease in the first child. But the transplants after that, which followed, had this very intriguing disease, which was named a second disease. So parallelly, at the same time, this was demonstrated in rats that they can develop after what we call as a splenocyte injection, which is equivalent to a hematopoietic stem cell transplant. They would develop weight loss, diarrhea, skin and fur changes, and they will die because of it. And as a result, some canine models were studied, and hence was the discovery of what we call as dog leukocyte antigen system, and which led to the discovery of human leukocyte antigen system, and that kind of paved the way for understanding of this condition, which was that time known as second disease, but later on was labeled as graft versus host disease. And this graft versus host disease, that time, very early in the 1960s, it was understood that it happens in administration of immunocompetent cells to someone who's immune compromised and unable to mount a response to the graft. And this immunological disparity between the host and the recipient can lead to graft versus host disease. So first time in 1960s, methotrexate was used in canine models, and that was shown to prevent graft versus host disease. And in 1970s, first time, the same group led by Sir Donald Thomas used cyclosporin as well to prevent graft versus host disease. So that's a little bit of history of this intriguing disease, which was initially kind of took a few years to understand the pathology behind the graft versus host disease. So we already heard a couple of cases one on acute and one on chronic GVHD. So we all know acute GVHD, usually happens the first 3 months of transplant, but it is not a rule. And we saw the case which is presented second. The acute GVHD symptoms were, the gut GVHD presented at almost 10 months post-transplantation. But usually they present in the first 3 months. And we know the typical organs are skin, liver, and gut. But there can be other organs as well in acute GVHD. For example, brain can be sometimes involved. You can have a renal involvement. You can have other organ involvement as well. And it's a relatively common complication. It's 25 to 30% in identical sibling donors, and it can be up to 80% in unrelated or mismatched transplants or the haploidal transplantation. So the incidence can be pretty high in some of these non-family donor transplants. Chronic GVHD, on the other hand, is mostly present after 3 months of age, but 3 months of transplant. But again, we saw the case which Siddharth presented was a little earlier than 3 months. But it has a different pathophysiology. We'll discuss that a little later. It's like autoimmune disease, and it can affect organs which are mainly skin, mouth, eyes, but also can affect other organs which are listed here: musculoskeletal, genital, liver, and lungs can be affected as well. And of course, leads to significant morbidity and sometimes mortality as well. Fortunately, children, we don't have the risk of chronic GVHD is a little lesser than adults, but still almost 20-40% of the children can develop chronic GVHD as well. So what's the pathophysiology? A little bit difference in the acute and chronic GVHD. In the acute GVHD, the first step is tissue damage, which can happen because of conditioning which has been given to the patient, to the patients, and also sometimes infections. So there's a huge data on now gut microbiota and gut colonization, being one of the risk factors for acute GVHD, and that releases pro-inflammatory signals. Those pro-inflammatory signals, actually lead to the host antigens to be presented to the donor T cells, and those T cells get activated and migrate to the target organs. And the third step, of course, is response to that antigenic stimulus, and leads to inflammatory injury, and which leads to the target organ damage, especially the skin, liver, and sometimes other organs as well. Chronic GVHD, on the other hand, as I said earlier, is like autoimmune disease. It is inflammation which is induced by some trigger. Acute GVHD is the biggest trigger for chronic GVHD, and that leads to actually immune dysregulation, which especially the T regulatory cells, and that leads to loss of self-tolerance, leading to tissue damage, inflammation, aberrant repair responses, and fibrosis being the final step in the pathophysiology of the chronic GVH. Now, there are various risk factors. There was a question also put in the chat box about the risk factors. Acute GVHD, the most important risk factor is, of course, actually mismatch. But of course, if there's older age of the recipient as well as the donor, female donor, especially those who are multiparous females going to male recipient, if there's alloimmunization in the donor, depending on the graft versus host disease prophylaxis which we have used, and increased intensity of conditioning, myeloablative conditioning have more GVH than the less myeloablative, and of course the CMV disparity between the patient and the donor. Out of this, most of them are, I would say, non-modifiable, most of them, but yes, GVHD profile is something which you can modify, and that's what we're going to discuss today. Chronic GVHD, on the other hand, is more in unrelated donors, more with HLA mismatches, more with PBAC used as a donor source, and again, female to male, and TBI in conditioning has got more chronic GVHD. And the biggest risk factor for chronic GVHD, of course, is it's the strongest predictor is the acute GVHD happening, preceding the chronic GVHD. So we discussed, the history of GVHD. We discussed, the classification, and we discussed the risk factors. Now, coming to the topic for today is GVHD prophylaxis. What do we do to prevent graft versus host disease? And we all know that depends on what kind of donor type we are using, what disease we are treating, and what kind of graft source is being used. In an HLA matched donor setting, traditionally a calcium inhibitor plus an anti-metabolite is being used. I will discuss that in the next few slides. If it's a mismatched donor, actually a mismatched donor or a haplodonor transplantation, we can do a T-cell depletion, and we'll discuss that, the mechanism of doing that, or we can use a post-transfer cyclophosphamide as well as a GVHD prophylaxis for them. However, in the recent days, we are now using more and more ATG as well in prophylaxis, and there are new kits on the block like sirolimus, bortezomib, and abatacept, and we will have a word about that as a prophylactic agent. Calcium inhibitor, as I said, is one of the earliest GVHD prophylaxis which has been used. It was used from 1970s by E. Sir Donald Thomas. We have two of them commonly being used, cyclosporin and tacrolimus, and it does lead to reduce the activation of these activated T cells by various mechanisms. It's usually started at day -3, day -2, and we target the trough levels of cyclosporin depending on the type of donor, type of cell source, and type of graft, and also depends on what time point post-transplant. Initial few weeks, we keep the levels a little higher, maybe 200, 300, and then we usually keep levels between 100 to 200. Of course, it's very important to follow some of the sampling guidelines for cyclosporin. Better to not take from the lumen which has been used to infuse the cyclosporin, and also we have to monitor blood pressures, creatinine, and potassium levels, which are the side effects of using cyclosporin. Usually, the cyclosporin or calcium inhibitor is used for 6 months to 1 year. In a malignant setting, we try to taper off cyclosporin earlier on. We try to taper it by 3 months post-transplant, to reduce the risk of relapse of leukemia. In non-malignant settings, we usually keep it for a longer time because we do not want, there's no GVL we are expecting in a non-malignant setting. And usually, after 9 months to 12 months, we start tapering it. And usually by 1 year, they're off immunosuppression. The other calcium inhibitor which is being used is tacrolimus. The problem with tacrolimus in India is that we don't have an IV formulation available. And of course, we target the levels between 7 to 10, 5 to 15 is the range. It has got almost similar toxicities as the cyclosporin. And of course, we have to look for the drug interaction, especially azoles are required in the treatment, and we need to monitor the levels more closely. So that is tacrolimus. Now, getting on the antimetabolites, which is the other agent which is commonly used is methotrexate. This was the first agent, as I said earlier on, tried first in canine models and then came to human models as well. And we know methotrexate is given, as day +1, day +3, day +6, and day +11, 15 milligrams on day 1, and then 10 milligrams per meter square on the rest of the days, which is always to be followed by leucovorin rescue. And of course, toxicity of methotrexate is, it can lead to probably higher doses of mucositis, rates of mucositis, can affect count recovery a little bit, and it can be hepatotoxic. So these are some of the things we need to kind of monitor with methotrexate, but it's one of the commonest agents being used with calcium inhibitor as the GvHD prophylaxis. The other antimetabolic which is used is mycophenolate mofetil, and we know it's a prodrug of mycophenolic acid, and we have two formulations. One is the mycophenolate sodium formulation, and one is a plain formulation, and we use them in 10 to 15 milligram per kg per dose, 2 to 3 times a day, and it's usually in a match-related setting. If you are using it, use for a month or so for post-transplant, and if an unrelated setting, we're using it, use for 2 to 3 months. And of course, one of the commonest side effects to be known about mycophenolate is two. One is it can be myelosuppressive, especially when used concurrent with ganciclovir. And the second is can somebody lead to GI intolerance, leading to vomitings and diarrhea. So that's those two common side effects we need to keep in mind when we use mycophenolate. Now, most of the times, as I showed in that algorithm before, that we use these in combination. The most common combination which is used is calcium inhibitor with antimetabolite, and cyclosporin methotrexate is the one which is was used the first, and it has been standard of care for many decades now. It was used first time in 1980s, and what it shows is that cyclosporin alone or cyclosporin methotrexate, when used with combination, the rates of GvHD, both grade 2 to 4, in some of these groups, it was a malignant group, and in aplastic anemia patients, both disease groups, there was a significant reduction in the graft versus host disease, and it emerged as standard of care after these landmark studies done in 1980s. Now, the second combination which is used often is called tacrolimus methotrexate. There have been studies, head-to-head comparisons as well between cyclosporin methotrexate and tacrolimus methotrexate. It emerges that tacrolimus methotrexate usually is a little better from the acute GvHD prevalence point of view. The rates of GvHD are a little lesser than cyclosporin methotrexate, but there was no difference in the survival curves in the two cohorts. Tacrolimus methotrexate is still preferred in US, and cyclosporin methotrexate is preferred in Europe. So we in India prefer cyclosporin methotrexate over tacrolimus methotrexate just for the simple reason of not having IV preparation available. And initial, when there's mucositis and initial phases of transplant, may be a little difficult to sustain the uniform levels of tacrolimus during that phase. But I know some of the centers do prefer tacrolimus as well here as GvHD prophylaxis. But they seem to be comparable. TAC methotrexate a little bit better from the GvHD prevalence point of view, but overall survival seems to be similar. The other combination which is commonly used also is CNI plus MMF, and there was some again a comparison between CNI MMF and CNI methotrexate. With a thought process that when we use MMF, there may be less mucositis and less need for analgesia. However, it wasn't shown. There are various systemic analysis reviews done on this, and there was no difference in GvHD and graft relapse or even the mucositis. And there's a trend now, which all over the world, that in a reduced intensity transplant, RIC transplant, CNI and MMF is preferred or CNI MMF, but in macular transplant, still methotrexate, CNI CNI methotrexate is used as a choice of GVHD prophylaxis. Only if you're worried about methotrexate for some reason, especially liver disease, then you can choose MMF or methotrexate or MMF or methotrexate as GVHD prophylaxis. So that was in the match settings. So what are the different options and comparison between those? Now coming on to the haploidentical transplant setting, we know there are two major platforms which are being used. If you see this cartoon here, it shows us what the T cells can do. If there are less T cells in a haploidentical transplant setting, of course it can lead to graft rejection. If there are more T cells in the graft or activity T cells in the graft, it can lead to higher rate of graft versus host disease. Now, the post-transplant cyclophosphamide emerged as one of very, very important and very feasible options in haploidentical transplantation. And we know that what happens in post-transplant cyclophosphamide, that we let these alloreactive T cells to proliferate, and proliferation is maximum at 72 hours post-transplantation, and that's the time when you administer cyclophosphamide at day 3, day 4, and kill these alloreactive T cells, which would have later on led to graft versus host disease. So that is one mechanism of where how the PTCY works, and that's why we do not give any other immunosuppressants to these patients before day +5. However, it's also known that PTCY also is a very important mechanism of setting up tolerance between the patient and the donor, and that happens through various mechanisms. The most important being its role in maintaining T regulatory cells, which minimize GVHD as well as set the tolerance between the recipient and the donor. So what's the experience with PTCY? If you see the initial Baltimore experience, wherein they initially was actually pioneered. Acute GVHD, 46% had acute GVHD, but only one of them had a fatal GVHD out of the 13 patients. The same group had more number of patients in the later publication, and grade 2 to grade 4, 34%, and grade 3 to grade 4 was very low, 6%. So very low grade 3, grade 4 GVHD with PTCY from the experience from that group. But these are all both these kind of data sets were reduced intensity transplants using the Johns Hopkins protocol. But if you look at some more data, irrespective of the ages and indications, the GVHD rates have been pretty much in the range of 20 to 40%, with grade 3, grade 4, not more than 10 to 15%. However, we know that PTCY does delay immune reconstitution and can be cardiotoxic. This is one of some of the concerns with PTCY. Now, PTCY, I think most of us, have started using PTCY beyond haplotransplants. And the most important, I would say, indication at this point of time is matched unrelated donor transplants. The data is emerging that PTCY is an effective, potent GVHD prophylaxis, both in a matched setting, whether it's unrelated or a matched sibling setting. And we have some data from India as well, where the matched sibling setting PTCY has been used with very acceptable rates of graft versus host disease, very low chronic GVHD, and more importantly, brings down the cost of treatment, as the cyclophosphamide is quite cheap, and we don't need to give them prolonged multi-agent GVHD prophylaxis, which can be expensive. Now, the second strategy which can be employed for haplotransplantation as GVHD prophylaxis T cell depletion. And we have various mechanisms of T cell depletion. The old method was, selecting CD34. So then you're just selecting stem cells and removing everything else. You have removed all the T cells, B cells, NK cells, and everything has been eliminated, and CD34 cells only being given to the patient. It has got advantage of least GVHD, but the problem has been prolonged, has been delayed immune reconstitution, because we have removed everything and also raised high rates of graft rejection. Now, the other mechanisms of doing was CD3 and CD19 depletion. They are removing T cells and B cells. Of course, in this setting, some of the NK cells, the dendritic cells will be left behind. Again, a little better than CD34, but not up to the mark still. Nowadays, we used alpha beta depletion. That means you're removing the alpha beta cells from the T cell repertoire, which are notorious to call graft as a source. You leave the gamma delta cells in the graft, you leave the NK cells in the graft, and those are the cells which will have, which will lead to better immune reconstitution, have some antiviral properties, and we achieve less GVHD here, but also a better immune reconstitution and less risks of GVH of relapses. CD44RA depletion by itself is not a prophylaxis for GVHD, but I think we do have some memory cells which can be infused along with the graft, which can be co-infused with alpha beta depleted graft, or it can be used later on as a DLI, and it does help with immune reconstitution as well, with very acceptable levels of graft versus. This can be another way, that is T cell depletion. There are various mechanisms of doing it, so we can use that as a GVHD prophylaxis in the haplotransfer setting. So what about T cell depletion? Some data on that. I don't want to go into the details of that, but the GVHD rates with the alpha beta depletion or other types of T cell depletions have been pretty low. In fact, grade 1, grade 2, most of them are in the range of 20-30%, and grade 3, grade 4 are less than 5% in the data which we have from our country, from Germany and other centers in the world. So it's a very good GVHD prophylaxis strategy. Of course, it has got its own concerns of delayed immune reconstitution, viral reactivations post-transplant. As I said earlier on, ATG is also emerging as a very good tool for GVHD prophylaxis, and ATG does cause in vivo T cell depletion in blood and lymphoid tissues, and it has been shown to decrease chronic GVHD in both related as well as unrelated donor settings, and it has been shown to reduce acute GVHD in unrelated donor settings, not much in match-related donor settings, and of course give a better GVHD-free survival. However, of course, again, it's a ATG, so we have a little high risk of infection, especially EBV reactivation. Alemtuzumab is another serotherapy which has been used. It's an anti-CD52 monoclonal antibody. Similar role as ATG, widely used in the UK, but of course it has got little high risk of infection relapses as compared to the ATG, but again, a good GVHD prophylactic agent, especially in the unrelated donor settings. And there's an enormous amount of data from Europe on this. But there are various ATGs available. We have got horse and rabbit ATGs. Rabbit ATG is the one which is preferred in transplants, in hematopoietic stem cell transplants. And for that, we have two preparations. So one is thymoglobulin and one is grapholon. These are used in two different dosage regimens. Grapholon is usually used in the range of 30 milligrams to 60 milligrams per kg. Thymoglobulin is used from 2.5 to 7.5 milligram per kg. Higher dose in mud transplants, lower dose in match-related donor transplants. And also, there's we recently had a very interesting session which we all witnessed with the Dr. Jab Borland's group, where they used thymoglobulin, which is based on the ALC, the lymphocyte count at the time of start of conditioning, and you can tailor your dose of ATG based on the absolute lymphocyte count, and not have too much of ATG left in the recipient post-transplant, which can impair the immune reconstitution. So that's one way of also smartly using ATG in the transplant setting. I won't go into much details of that. There's also a Beijing protocol, which is being used by the Chinese group in haplological transplantation. They use PBAC and marrow graft together, and they use a very intense conditioning with ATG in their prophylaxis, and that's one of the ways also to use. So these are the three strategies. One is first one is Hopkins protocol, non-myeloablative, myeloablative. In both the things you can use PTCY, great, day 3, day 4 with MMF and tacrolimus. The Chinese protocol, you use intense ATG conditioning from day -5 to day -2, and they use MMF cyclosporin post-transplant with methotrexate as the GVHD prophylaxis. It's the strategy which they have adapted. In cord blood transplant, we don't do many cord blood transplants in India these days, but yes, cord blood transplants, also the risk of GVHD can be around 30 to 60%. Most of the GVHDs in cord blood are fortunately steroid responsive. And the methotrexate has usually been avoided in in cord blood transplants for its negative impact on count recovery, and cyclosporin tacrolimus MM has a commonly used GvHD prophylaxis, as well as serotherapy with ATG. So and again with cord bloods, because they have tendency to have less graft versus, especially there's a good match. The immunosuppression taper starts a little earlier than the PVAC graft. So newer kits on the block, one is sirolimus. Sirolimus is the mTOR inhibitor. It is it also suppresses the T lymphocytes, but it preserves the T regulatory cells, which is not the case with CNIs. So one of the advantages of using sirolimus is that you can preserve the T regulatory cells, and hence the risks of GVHD are a little better than as compared to CNI. Again, it can be used with CNI, like a tacrolimus sirolimus combination. It can be used sirolimus with antimetabolite. The most common antimetabolite used is MMF, and we have also data from our own country on sirolimus, especially in the sickle cell anemia setting, and the risk of thrombotic microangiopathy is there with sirolimus, and we need to kind of be aware of that. The only concern I think we have been again with sirolimus is that it's not available in IV formulation, and that the levels of sirolimus are not readily available at the center. So it takes sometimes 1 or 2, 3 days to get the levels back, and that is some of the challenges with sirolimus which we face, but a very, very, very interesting agent as well as for prophylaxis. Another agent which has shown a lot of promise is called abatacept. Abatacept actually blocks co-stimulatory molecules on the antigen presenting cells, so with the T cells, and it kind of it stops, it prevents graft versus host disease at the initial step, wherein the antigen presenting cells are presenting the antigens to the T cells, and there's a blockage there of the co-stimulatory molecules. It's used in in the format of day -1, 5, 14, and 28. It has shown very promising results of having GVHD, severe GVHD grades figure for less than 5%. And we have some data on this from India as well. This is one of the publications which were actually collected for a multi-center study on aplastic anemia. And when we had collated this data, we saw the group who had used abatacept, the GVHD rates definitely were far, far less than the other GVHD prophylaxis. In this was haploidal transplantation or aplastic anemia in this setting. So it's a promising agent, and I think holds a good promise for future as well. There are many other agents used in prophylaxis, including bortezomib and some other agents, including epigenetic modifiers, which are being tried, but we don't have enough data for them at this point of time to be used as standard of care. So to conclude, they say that prevention is better than cure. So I think the best management of GVHD is to prevent it, and prevention will be applicable with what we know as personalized approach to GVHD prophylaxis, depending on patient factors, depending on what risk the patient has before transplantation, what disease we are dealing with, whether it's a malignant or a non-malignant disease, what kind of immune reconstitution we're expecting post-transplantation, and also the donor factors, the type of donor, type of graft, whether it's marrow, PBSC, whether done any graft manipulation to the graft. I think all of that will determine our GVHD prophylaxis, and I think we should tailor it to each and every patient and minimize the GVHD to as much as possible, because when it happens, it not only leads to increased morbidity, but also huge mortality and also financial toxicity in our country. So to summarize, GVHD is better to prevent than treat. Prophylaxis should be tailored based on the transplant setting and indication. And we do not actually want any GVHD for normal diseases. In malignant diseases, of course, some amount of GVHD may be acceptable and sometimes beneficial in view of the GVL effect. Calcium inhibitors are anti-metabolite standard of care, but there's a huge upcoming role of post-transplant cyclophosphamide, even in match setting, especially in unrelated donor transplants. Haploid transplantation, they need T cell depletion, which can be done by PTCY, or it can be done by ex vivo techniques like T cell alpha depletion. And ATG is being increasingly used in conditioning to reduce both rejection as well as GVHD. And of course, there are new entrants and new kids on the block. Sirolimus, abatacept seems to be the two promising ones and are increasingly being used in this setting. So thank you very much, and we'll later on take questions if you have any. I'll hand it over back to Preetham for having the next talk. Thank you very much for your attention.
Thank you, Dr. Sunil, for that masterclass in prevention of GVHD in hematopoietic stem cell transplant. There are a couple of questions here, but as you said, I think it's better if we take the questions together once Dr. Chintan has finished his talk, if you're able to stay till the end of the talk. Is that all right?
That's absolutely fine, Vandana. No problems.
Yeah. Okay. Thank you. Right. So I will now invite Dr. Chintan Vyas, who of course is no stranger to this audience. He's a consultant at NHSRCC Children's Hospital in Mumbai, and he will be talking to us about management of graft versus host disease. Over to you, Dr. Chintan.
Yeah, thank you. Thanks a lot for giving me an opportunity to talk on this topic. And thanks a lot, Dr. Sunil, for setting the stage. Wonderful to listen to you always, because as he has said in this conclusion slide, the first slide, it is always better to prevent and then the treat. But unfortunately, we as a pediatric transplanter are dealing with such a situation where we, particularly in the malignancy setting or nowadays in a lot of non-malignant transplant, we have to choose an alternative donor, because as we know that matched sibling donor is not available to everyone. And even in matched sibling donor, the risk of GVHD is not zero. So we have to understand the ways to find out how to treat it in the earliest possible way, so that we do not lead the patient in a comorbid situation, treat the cancer but leading to the comorbid situation, or treat the thalassemia and making the patient bound to drugs for GVHD. So I have maybe 20 minutes odd, and I would like to finish both acute and chronic GVHD management, which is a mammoth target. But what I'll do, I'll just basically tell about the brief, how do we manage GVHD, how do we diagnose GVHD as well as manage GVHD in a day-to-day scenario. Now, we all know that why GVHD happens. And the basic three principles of the GVHD is that the graft must contain immunologically competent cells. The recipient must express the tissue antigens not present in the donor, and the recipient must be incapable of mounting an effective response to transplanted cells. This is the basic reason why GVHD happened. And we all discussed that what are the risk factors of GVHD: mismatched donor transplant, older age of donor, female multiparous donor, particularly in the male recipient, mild ablative or higher intensity of conditioning regimen, and acute GVHD had happened if it has happened in the first stage. And it starts not only maybe after a few days after engraftment, it starts right on the engraftment. So how fast your engraftment is happening and what best your the GVHD preventing prophylaxis, that all will determine how your GVHD is going to happen. Now, to diagnose GVHD is most important, and the reason why I'm pressing on diagnosis, because that is going to give you a clue how to manage. And we all have understood that GVHD 100 days, the border is no more that much relevant, because we have seen some of the GVHDs manifesting like an late acute or chronic GVHD presenting on day 60 of transplant. And then we always say that, look, this doesn't happen so early, but we have faced this situation now in many years. So classic acute GVHD, yes, before 100 days, but you have persistent, recurrent, late onset acute GVHD happens after 100 days also. And the same happens with the classic chronic GVHD after 100 days, but it can happen before also, particularly in some of the organs. This is just a rough diagram of how do we manage. But the important thing is that when we try to initiate the treatment of GVHD, the main basic message is that we have to evaluate daily. It's not that we have started a treatment for ITP where we evaluate, where we give 2 weeks of steroid and then taper down. That's not the way GVHD is managed. GVHD is managed when we are evaluating daily. After every third day, we are reassessing what we are dealing with, the situation, whether the GVHD stage is progressing or whether there is any response. And that is a stage will help us to start thinking about the second line treatment earlier rather than being it so late. And that's the thing. Monitoring every 3 to 5 days of your GVHD treatment in acute phase is the most important, not only just to code a refractory GVHD, but also to see how fast you need to taper down your immunosuppression or how slow you need to taper down your immunosuppression. As the commonest symptoms of acute GVHD, skin, liver, and gut is the commonest thing, and majority of the organs are being, majority of the times the skin is mostly affected, and followed by GI and the liver. GI can be in upper and lower GI tract, as I have mentioned here. The liver GVHD particularly less commonly affect. Sometimes it doesn't affect isolated. It can affect with it can happen with the skin GVHD or maybe upper gut GVHD. And the way liver GVHD happens is also not a book picture. You may not see always the hyperbilirubinemia or the classical liver GVHD picture. So you have to find out clinically why your patient is having liver GVHD. Lungs are the most important part of GVHD, which is sometimes we always think about infections, and then we have to determine whether this is infection or this is something like inflammatory phenomenon going in lung. And I would say that previously we used to say that lung GVHD happens after 100 days, after maybe 3 months or 6 months, when the fibrotic mechanisms takes place. But sometimes you do get lung GVHD or maybe early kind of pulmonary GVHD in acute phase also, and that starts right from the engraftment, and it can happen beyond engraftment. So the GVHD diagnosis that is why it is very important that how can it mimic to an infection, how can it should be differentiated from infection, and the timeline is the one which you need to decide clinically rather than just going by the book picture. Differential diagnosis should always be taken care of. The reason why differential diagnosis should be taken care, because you have to rule out infection before quoting any patient for acute GVHD, and also you have to rule out the drug toxicity. Very rarely, the skin rash or maybe gut GVHD could be a part of your drug toxicity, like MMF cause colitis. Some of the drugs cause drug rashes, and those are the things which we need to look at when you are diagnosing the GVHD, because that is most important when you are managing the GVHD. And again, you have to look at the viral causes of GVHD, viral infections or bacterial infections, which can mimic your differential diagnosis for GVHD. I would not go into the detail of this grading classification, but why it is important, just because there are some students also there, why it is important to grade and stage GVHD, because your management depends on grading and staging GVHD. Grading means a histological diagnosis, but staging means your clinical diagnosis. So you have to stage the disease well, and once you stage the disease well, whether it is skin, liver, or gut, then you modify your treatment based on what your staging you are dealing with. We will discuss what stage, how to treat. Now, the supportive care is also important. As I have talked, that GVHD is not only you are dealing with immunosuppression, but you are also dealing with coexistent infections, and which can go hand in hand sometimes. You don't have to wait for infection to happen. You have to treat the infection, prophylax against the infection simultaneously. So to monitor viral PCRs, managing the side effect of the drugs, control the blood pressures, control the sugars, and those are the things which are very important when you are managing acute GVHD or for that matter, chronic GVHD also. So how do you manage skin GVHD in stage 1 stage? Means if you have a limited less than 25% of body surface area or 25 to 50% of body surface area, you can manage with the topical agents. But when it is getting more than stage 1 GVHD, means more than 25% of body surface area, then you have to think about starting some sort of systemic immunosuppressions like an oral steroids. Topical agents, 1% hydrocortisone to be applied on face because it is a less potent steroid, and mometasone or desonide to be applied on the rest of the body because it is more potent steroid. In resistant case, you can use 0.1% or 0.03% of tacrolimus ointment also, particularly when we are dealing with a resistant kind of skin GVHD, and it can help in chronic GVHD setting also. Steroid dose, it is usually 1 milligram per kg. Here we are dealing, so all steroid dose is not 2 milligram per kg. It is 1 milligram per kg for skin stage 2 and or stage 1 upper gut GVHD. So when you are dealing with limited upper gut GVHD, where you only have anorexia, gut nausea, vomiting, a bit of weight loss, low grade fever, or limited skin to stage 2 skin GVHD, you need to start with 1 milligram per kg per day of steroid for 2 weeks, then tailor down accordingly to 0.5 milligram per kg per day for subsequent 2 weeks, and then you see how you need to taper it down. So usually the duration of this limited acute GVHD is somewhere around 4 to 6 weeks. You don't have to continue for 3 months or like that in acute phase. Similar dosing is used for upper gut GVHD. If response is not seen, then you may escalate the dose of methylprednisolone to 2 milligram per kg. But again, whenever you are not seeing the response, you need to rethink, are we dealing with a coexisting infections? Is there any viral reactivation going on? And then you treat accordingly. Like in the case, in the previous, our students described that there was a CMV also reactivated while treating the GVHD. So that you need to remember. In the grade 2 to grade 4 GVHD, acute phase, gut, lower gut, you need to start with 2 milligram per kg, and then 1.5, then 1, and then taper down. So the tapering down of the steroid should be assessed either every 10 days or 14 days. So 2 weeks is the time. And then if you have a difficulty in weaning down on the steroids, you may reintroduce the agent which you have stopped in the beginning, like MMF. If it is stopped by day 35, you can reintroduce that, or cyclosporin if it is stopped in a non-malignant setting. In a malignant setting, early weaning has been done, you can reintroduce that. Isolated acute liver GVHD does not happen too oftenly, but yes, if it happens, you have to start with 2 milligram per kg of the steroid, not 1 milligram per kg, and then you taper down accordingly. This is about the steroids. Now, when you are not seeing the response on the steroids, that time you need to see that how much you need to think about the steroid refractory GVHD. Now, this is a very classical slide when you do not see the response on maybe on 3 to 5 days of treatment. You have a clear progression from one stage to another stage, stage 2 to stage 3, or stage 2 to stage 3 to stage 4. You need to think about steroid refractory GVHD. Or you have no response at all by the end of 7 days. And then you need to think about the second line treatment, which I will be discussing in subsequent slides. Now, for the steroid refractory GVHD, there are a whole lot of medicines which I have discussed in this slide particularly. You can see there may be 15 odd medicines, but how to choose, where to choose, and what medication is cost effective in Indian setting, that is most important. Before the ruxolitinib came into the market, there were a lot of monoclonal antibodies have been used, and this concept came from the autoimmune disease treatment, that people have realized that if you block the antibody level things, then probably your GVHD will be better taken care of. And that's how the infliximab, daclizumab, basiliximab, all those came into the picture. We have used infliximab in few years before the Jakavi came to the picture and used quite often. And infliximab, basiliximab, or daclizumab. What is infliximab? It is TNF alpha blocker. Daclizumab is again monoclonal antibody against IL-2R receptor, which is very important for T cell proliferation. And basiliximab also is acting on a similar agent, similar way, while the daclizumab, how the daclizumab works. But the most important problems which we find, yes, they are very good drugs. They control GVHD in acute setting quite nicely. They are injectable, so we don't have to worry about the absorption. But yeah, they do come with a lot of infections. We have used infliximab in some of our patients with 10 milligram per kg IV on weekly basis, day 1, 8, and 15. And then 22, and then also continue steroids together. And then start tapering steroids as you see earlier the response to your monoclonal antibodies. The new kid on the block is JAK inhibitor, and nowadays it is no more a new kid on the block because everyone is used to this drug for last at least maybe 4 or 5 years. The dose is 5 milligram or 2.5 milligram, and then you go up to 10 milligram BD dose, which is an adult dose. But the mechanism here in of JAK2 inhibitor is it predominantly acts at multiple level. It not only blocks the downstream regulatory pathway, but it also blocks the cytokine storm, which is coming from the coming in the phase of acute GVHD. Yes, this drug, when it was introduced for the chronic GVHD, because all the people were thinking that this JAK-STAT mechanism is mainly leading importance in the chronic GVHD, where you have a more fibrotic mechanism taking place, or maybe like more tissue infiltration taking place. But it does definitely takes a role in acute GVHD setting also, and it is proven now quite nicely in any randomized control trials. So there are 3 JAK2 inhibitors, JAK1 and JAK2 inhibitors: ruxolitinib, itrasitinib, and baricitinib, in which Indian setting we are available with ruxolitinib, and we can use this drug in acute GVHD in a steroid refractory setting as early as by day 5 or day 7. So you don't have to wait for 2 weeks to see to wait for the Jakavi to introduce. So you can use as early as 1 week if you are seeing a clear progression of the GVHD symptoms in 1 week of steroids, or maybe in 5 days of steroid. What dose to use, again based on the weight and how much you are how much the counts of the patients are. Previously, there was a lot of hesitations of using GVHD in a thrombocytopenia or in a low count. But now, as I say, that thrombocytopenia is also not an absolute contraindication of using Jakavi. And as the GVHD gets treated, the thrombocytopenia definitely gets improved. The third line agent like mesenchymal cells or ECP, I'll discuss again in the later time when I'll be discussing about the chronic GVHD. But those are also promising agents, unfortunately not easily available in Indian setting, and particularly mesenchymal stem cells and ECP. Very limited options, very limited centers are doing, but they are also very important and nice treatment, particularly because they are the risk of infections are quite less, particularly with ECP. If I would be in abroad, the ECP is considered as a second line drug because the availability of ECP is so easy, so that they can use ECP in a quite regular way. And ECP is a treatment where you don't need to too much worried about the antifungal, antiviral prophylaxis, because that doesn't cause too much of viral reactivations and also the fungal infections. And it can go on outpatient basis also. You don't have to keep the patient admitted for that, particularly for the ECP. We'll discuss later again on the chronic GVHD time talk. The few more treatment strategies like fecal microbiota, bortezomib, pulse methylprednisolone, pentostatin, alemtuzumab, all these medications, or ATG for that matter, all these medications have been used, but not very consistently. So if we want to define the treatment, maybe the first line treatment, second line treatment, or third line treatment for an acute GVHD in a steroid responsive or a steroid refractory setting, probably the one which I have described in my slide, the steroid, Jakavi, and other agents like cyclosporin, MMF, tacrolimus, sirolimus. Those are the important agents. And yes, if it doesn't get help, probably ECP and MSC, infliximab, basiliximab, low dose methotrexate, etanercept. All these options are there for the acute GVHD. They also do come with a lot of risk of myelosuppression and unpredictable efficacy. Let's say previously we used to use low dose methotrexate and etoposide, but sometimes it adds on myelosuppression, and we don't know exactly how fast it will act. So nowadays the treatment paradigm has been shifted from those old agents like monoclonal antibodies or etanercept, methotrexate, to a newer agents like Jakavi. So now move on to our second part of the talk, which is chronic GVHD. And here I will spend more time. The reason why I will spend more time, because it lasts longer, and also there are various spectrum of chronic GVHD. Acute GVHD is a little bit simple, like skin, liver, gut, and maybe sometimes lungs. But chronic GVHD comes with a hell lot of complications. It goes on and on, and that's how the treatment response assessment is also quite different compared to acute GVHD. The risk factor remains more or less same: HLA disparity, unrelated donor, or a haploidentical donor, PBSC use, female donor into male recipient, inadequacy or not able to do T cell depletion because of the reasons, older recipients, underlying diagnosis, particularly in CML and MDS kind of situation, prior infections, prior GVHD, and withdrawal of immunosuppressions at some of time. So these are the risk factors. And the main difference between acute and chronic GVHD at the pathophysiological stage is acute GVHD is aggressive phenomenon, destructive, leads to mainly because of the T cell infiltrates, while the chronic GVHD is relatively acellular fibroproliferative state, and it can lead to more of kind of fibrosis, be it lung, be it liver, or be it GI tract or skin. So there's a little bit difference in the pathophysiology between these two phases. And the phases of chronic GVHD, again, it's either acute inflammation or chronic inflammation by dysregulated autoimmunity or tissue fibrosis. So these are the common pathophysiological mechanisms. In the next 3 or 4 slides, I would like to just show the pictures of chronic GVHD just to diagnose, because if we diagnose these symptoms, then only we'll be able to manage. These are some of the pictures of lichen planus, or some depigmentation of the skin, erythematous lesions. So you can see that it can not only present with classical erythematous maculopapular rash with itching or without itching, it can present with a lot of different variation in the skin, lichen planus, lichen sclerus, some hypopigmented area, leathery skin, depigmentation, deep sclerosis, like waxy tired looking skin, poikiloderma, atrophic or pigmentary changes, telangiectasia, keratosis, erosions, rashes, and then it can lead to also reticular formation, ulceration, and like nodularity also can be seen either in oral or GI tract. You can see dystrophic nails, the fasciitis, the keratoconjunctivitis, and Schimmer's test, which we do for the dry eye. So all these various spectrum of chronic GVHD, which we deal with. The things which I have not included in the diagrammatic form is a lung GVHD, and it requires a CT scan plus some pulmonary function test, which I'll come on in the next subsequent slides. So again, to diagnose chronic GVHD, step 1 is to distinguish from acute GVHD. The pattern of rashes of acute GVHD is different from the chronic GVHD. Step 2 is at least one diagnostic manifestation, and then if you are dealing with some systemic GVHD like oral, musculoskeletal, or lungs, then you have to do the defined test for that, and then rule out the possible infections also. So biopsy, yes, whether it is acute or chronic, definitely you should attempt the biopsy whenever it is possible, but not always it is possible in all the setting. But yeah, particularly when you are dealing with some different morphology of the skin rash or unexpected GI manifestation, then you may need to do a biopsy to see whether this is a drug induced injury or infections, or it's a refractory or kind of GVHD. For a lung GVHD, there are two type of lung GVHD. One is obliterative, means obstructive lung GVHD, and the second is restrictive lung GVHD. For the obstructive lung GVHD, it is similar like an emphysema. You do need to do a pulmonary function test if the child is more than 8 years or 10 years of age. Many times it is difficult because the child is anyways wheezing, coughing, in respiratory distress. So when the child settles down, then you do the pulmonary function test to see what kind of lung function you are dealing with. But the HRCT is most important, and you have to tell your radiologist to try to do the CT scan in an expiratory phase. So if you do the CT scan in an expiratory phase and in a high resolution CT scan, you can definitely see the classical lung picture in the form of small airway obstructive phenomenon or a bronchiectasis. If you just, sometimes it is very evident, then you can definitely see in the lung, in the whatever HRCT you do. Other systems like esophageal or upper GI, if there is a significant the swallowing problem, you need to do barium swallow or endoscopy. There may be a classical wasting syndrome associated with that. You need to rule out infections and drugs for that. Bronchiolitis obliterans, as I've already mentioned, and cryptogenic organizing pneumonia, means bronchiolitis obliterans organizing pneumonia. And then you need to do rule out the infections. So whenever you are dealing with a lung GVHD, particularly in a chronic phase, again you have to think whether I'm dealing with a flare of infection, or it is a simple ongoing lung GVHD, or it is a new phenomenon which you are dealing with. Remember one thing, that whenever you are dealing with lung GVHD, you need to rule out any infections also, because most of the times they flare on infection, whether it is upper respiratory infections or lower respiratory infections. So in that case, you have to treat both together. Not hesitate in starting methylprednisolone high dose, even if you are having some infections, because you know that clinically this is a GVHD flared by infection. Another very different and difficult chronic GVHD phenomenon is myositis or musculoskeletal, and for that you need to do the entire musculoskeletal system examination. So the treating based on whether you are dealing with a limited GVHD or extensive GVHD, whether you are dealing with mild, moderate, or severe GVHD, whether you have any associated risk factors like thrombocytopenia, hyperbilirubinemia, or ongoing corticosteroid treatment, that you need to look at. and thus how you define whether you are dealing with a limited chronic GVHD or you are dealing with a extensive chronic GVHD, or for that matter, based on the NIH criteria, mild, moderate, and severe. Now, what topical agents can be used for oral? Dexamethasone rinse, tacrolimus 0.1% ointment. Sometimes, if you are dealing with the musculoskeletal GVD, you can use intralesional, intra-articular, intralesional triamcinolone. Antifungal prophylaxis needs to be continued. For the lichenoid-like lesions, you may sometimes need to use tacrolimus ointment if they are not responding to steroid ointment, and PUA therapy. For ocular, you may use preservative-free rewetting drops. Cyclosporine eye drops are also available, and sometimes fluid-ventilated gas-permeable scleral lens. But most of the times it gets treated with the eye drops. And pulmonary GVHD, the starting treatment for pulmonary GVHD is the FAM therapy, and the FAM therapy is fluticasone, azithromycin, and montelukast. So this is the one thing which you bang on it to start on the first when you are dealing with a lung GVHD, apart from the systemic therapy. Now, how do you use systemic therapy? Here, the systemic therapy dose is 0.5 to 1 milligram per kg and not to 2 milligram per kg. And then taper down very slowly, taper to alternate day with or without cyclosporine and tacrolimus if it is ongoing. Use the minimum dose sufficient to control GVHD manifestation. After disease has resolved, withdraw gradually, one at a time. Do not start to withdrawing 2 drugs at a time. So always focus on withdrawing 1 drug at a time. Taper until you see the evidence of exacerbation. Cycles of attempted tapering dose escalation until you reaches to the kind of physiological dose 0.1 milligram per kg per day, and then further discontinue after 4 weeks or after you reaches to the physiological dose. So as I have mentioned, the treatment duration for acute GVHD is maybe 4 to 6 weeks or maybe 8 weeks in the gut GVHD, but here the treatment goes on for maybe 3 months, 6 months, a year, or maybe more than a year. So you have to discontinue the treatment very slowly. You have to make sure that you reach to the physiological dose and then gradually taper down. The role of combination therapy, where you need to introduce something other than steroid. There are definitely some drugs which you can use if you have stopped it before, like cyclosporine, tacrolimus, and or sirolimus. You can reintroduce those drugs. You can use cyclosporine plus prednisone, but you have to worry about the side effects. Particularly when you are dealing with some kind of liver GVHD, you can introduce tacrolimus, because tacrolimus is the one which is metabolized by liver and works well. You can introduce MMF also, which also works well in liver and skin GVHD. So where would you use the systemic secondary treatment apart from the steroid, where your steroid is not causing the significant improvement, or if you have now seen the worsening, or if you are not able to taper down the steroid less than 0.5 mg per kg per day, or if you are dealing with a significant steroid toxicity like joint issues, like significant infections, mood changes, and all those things. So those are the situations where we need to consider the secondary systemic treatment. What are the secondary systemic treatments available? Again, same like acute GVHD, but here we can introduce some of the drugs which may not be useful in acute GVHD, particularly like rituximab. ECP, imatinib. Imatinib also is something for the chronic GVHD. The rest of the drugs remain same like acute GVHD. Principle of the secondary treatment remains same. There is no consensus, but the goal is to reach to a steroid-sparing state and to reduce the toxicity of the steroids. Early initiation is always better in severe chronic GVHD. Delay initiation, where you predict the improvement, will be very slow, particularly in a fibrotic skin GVHD or a musculoskeletal GVHD or a lung GVHD. Time to intervene, if you see no response in first 4 weeks. Remember, in acute GVHD, I have told you about the response assessment at every 3rd to 5 days. You assess maybe after 28 days or maybe earliest after 14 days, and then you taper down or switch to a newer agent or second line agent based on that. The pulse methylprednisolone or pulse steroids have some role, particularly in lung GVHD or in a refractory gut GVHD. You can use 4 milligram or 10 milligram per kg for short course, just to control the acute inflammation of the chronic GVHD, and then can move to a second line agent. Calcineurin inhibitor.
Chintan,
Yeah.
Sorry to interrupt. I was just wondering whether you could wrap up in the next couple of minutes, please. We're running out of time.
Yeah, Sure. So another agents like sirolimus or mTOR inhibitors can also be introduced with considering of the side effects. This definition of steroid refractory chronic GVHD, as I have mentioned, it is usually at the end of maybe 2 weeks or 4 weeks if you are not able to wean down less than 0.5 milligram per kg per day, or if you are progression on 1 milligram per kg per day. And the drug again same like ruxolitinib, which we have used in the first instance. And the important trials which we usually mention is the REACH trial, and the REACH trial are the only one which has proven significant efficacy of ruxolitinib, be it in adults and be it in pediatrics. And you can see the overall response rate on day 28 is shown in this REACH trial is as high as 60% compared to the best available treatment, which is 40%. So definitely the ruxolitinib, particularly in the REACH study, has shown significant improvement. Some of the rare drugs which we have used, I'll just go through some of the names, like thalidomide, which has been used in chronic GVHD setting. Imatinib definitely is used a lot, particularly in the fibrotic setting where you are dealing with the PDGFR or receptor problems. And there, particularly in the skin, musculoskeletal, and lung, the imatinib has worked significantly well. You can see in adults as well as in pediatric. The dose is somewhere between 200 to 300 mg per meter square or 375 mg per meter square. You can go and you can see how the skeletal manifestation or musculoskeletal or fibrotic skin manifestation shows significant improvement with imatinib. Rituximab has significantly has role because it blocks the antibody formation and leads to less fibrosis, less antibody formation, and can be helped in chronic GVHD setting. And this is a study, Gitmo study, where the rituximab has shown significant improvement. ECP and the mesenchymal stem cells, these are the two last resort which we usually use for chronic GVHD. ECP is again immunomodulatory management. It reduces the active T cells and try to increase the T regulatory cells. It can be very well used in outpatient setting also. Frequent sessions, maybe up to 3 months, 6 months, or year also it can be used. Side effect, no viral reactivations, no infections, no secondary malignancies. So very safe mode of treatment. The indication, again, steroid refractory GVHD or unsuccessfully been treated with more than 3 lines of the drug. Mesenchymal stem cells, it can, again, immunomodulatory effect, suppress the T cells and also control the milieu of the stromal things, and it can suppress a lot of cytokines like interferon, TNF alpha, and it can promote the good cytokines like IL-10 and IL-4, which can promote the T regulatory cells. Again, can be used for a couple of settings or maybe up to 4 doses, and it has shown significantly improvement in the gut GVHD or in the refractory skin or lung GVHD, up to 70 to 80%. The last, ibrutinib. Ibrutinib is also used for the chronic GVHD, particularly in the skin and musculoskeletal setting, with overall response rate of 70%. So here I would end my talk. Definitely chronic GVHD is a debilitating situation. The outcomes may not be that great. The use of PBS and all those things make the chronic GVHD much more vulnerable. But as I have told you, you have to know how to manage the initial complications, how to switch the drugs, how to look for the secondary agents, considering what are the side effects you are dealing with the secondary agents, and also slow and patient tapering of the immunosuppression is the key in chronic GVHD. Thank you very much.
Thank you, Dr. Chintan, for that very detailed explanation and going through all the parts of acute management of acute and chronic GVHD. That brings us to the end of the talks. I will ask a couple of questions. So the first question, perhaps I can ask to you, what is the role of topical budesonide administered along with systemic steroids for gut GVHD?
Yeah, so it is quite useful, particularly in the upper gut, also in the duodenum where the ulcers are there. It definitely helps a lot for maybe 2 weeks or 3 weeks. You can continue. You don't have to continue for 4 weeks or 5 weeks. Short duration of budesonide definitely help to control the initial phase along with the systemic steroids. It cannot be used only. Sometimes it can be used if there are only mild symptoms. But yes, I do use a lot in the gut, upper gut, or the proximal intestinal bowel GVHD.
Thank you. And Dr. Sunil, if I might ask you this question, risk factors for TTP secondary to CNI, and whether this risk is there with sirolimus as well.
Yeah, so yes, TMA, thrombotic microangiopathy is common with CNIs. Most of the times it's subclinical, subtle, and I think we also miss a lot of these. But if you prospectively look at it, there are some studies where prospectively they've looked at the TMA incidences. It can be quite significant. It's of course both with mTOR inhibitor like sirolimus as well as with the CNI, cyclosporin, tacrolimus, both a little bit higher for cyclosporin, and the combination of mTOR inhibitor, sirolimus, and at CNI, whether it's tacrolimus, cyclosporin, or plus sirolimus, incidence are even higher than the individual drugs itself. So yes, both sirolimus as well as CNIs are the risk factors for TMA, and it should be watched for, especially if you're using the two drugs together.
Thank you. One more question, perhaps, Dr. Chintan. Any preference for the choice of second-line agent for management of severe GVHD based on organ of involvement?
Right. So let us say if you are dealing with again a chronic, if you are dealing with a bad skin GVHD, the ruxolitinib also helps. And if you are dealing with a fibrotic skin GVHD, like in chronic GVHD, imatinib definitely helps. ECP we do not have readily availability, so I would not use that option very loud and clear. But yes, if it is available, then it should be used. For liver GVHD, MMF and tacrolimus works the best in my experience, and sometimes the sirolimus if it has been used in the previous setting. For a musculoskeletal GVHD, I would say again imatinib, rituximab, ibrutinib. These are the drugs which works best. And for the pulmonary GVHD, FAM therapy, systemic steroids, imatinib, and Jakavi. These are the agents which I usually prefer. Yeah. Sometimes some of the very bad joint disease, they have used anakinra and other drugs also, which I have not particularly used too often. But yeah, this is a choice of a second line drug.
Thank you very much. I don't think there are any further questions, and it just brings us bang on 8:30. So thank you very much for all of the speakers today who contributed to today's educational program. It was really insightful, and I'm sure people have benefited from your knowledge and expertise. So thank you again very much for joining us today and for sharing your expertise. This actually is the last last session for this year. So we come to the end, and it's also perhaps the last session for our team. So I'd like to just place on record at this point, Preetham and I want to place our gratitude to Dr. Amita Trehan and Dr. Neeta Radhakrishnan, who have been extremely supportive to us in running this program, to the ECHO team, who have been wonderfully supportive and hand-holding us each session. So really grateful to everyone, and to all of you for making it a fantastic success. I mean, at the peak of the class today, we had over 100 participants, so century. Well done, everybody. And most times we have between 80 and 100. Some are crowd pullers more than others, and so they see more. We see more participants. Overall, it's been a wonderful experience, and again, grateful to everybody for making it a fantastic success. Preetham, if you want to add anything, or Dr. Neeta or Dr. Amita, if you're here to add anything.
No, ma'am, you have beautifully put together the thoughts, and I echo to that. Just gratitude to the chairperson, the secretary of each chapter, the ECO team, and obviously the all chapter members who have been very helpful. And obviously all the centers who have always was just a phone call away to immediately participate and involve in this academic exercise. Thank you all. So our next session will be on 11th of January, but we as of now are yet to finalize the topic, speakers, and obviously we will obviously leave to that the next team who will
take handover from us to run the online teaching program on the subsequent years. Thank you.
Thank you very much, everyone, and have
Thank
a
you.
good night. Thank you.
Thanks a lot.
Thank you. Good night, everybody. Merry Christmas and Happy New Year.
Thank
Yeah.
you. Thank you.